Thank you again very much.
Yes, you're welcome.
So that was outstanding. Thank you very much, David. Our next speaker is Neil Epperson, who is the Robert Friedman Endowed Professor and Chairman of the Department of Psychiatry at the University of Colorado School of Medicine. Neil is a graduate of UNC, and after she completed her training there, she did her residency in psychiatry at Yale, stayed there until the level of associate professor, and then was recruited by the University of Pennsylvania to become full professor there. At Penn, she was also the founding director of the Penn Center for Women's Behavioral Wellness. Dr. Epperson is internationally recognized as for her role in women's reproductive behavioral health research across the lifespan, but perhaps one of her most important contributions has been to describe the impact of early childhood adversity in young girls, what I was talking about earlier during the introduction, on their subsequent physiological and psychological responses during periods of hormonal change. The work has been funded by the National Institutes of Health for over 2 decades, both through the National Institutes of Mental Health and the Office of Research of Women's Health. It gives me great pleasure to invite Neil Epperson to the stage. Thank you.
So I was telling Tracy Bale last night, I said, you know, it's really wonderful to be here. Audrey has really put together an amazing conference. But, you know, you had to schedule me right after David Rubinow. I mean, like, please. I mean, that's like my biggest nightmare is to have to present after David. I mean, that's amazing. Let's give David another round of applause. It was a wonderful talk. And it sort of reminds me of the old quote by Sir Isaac Newton. If I have seen further, it's because I stand on the shoulder of giants, and I've probably ruined that. But basically, Audrey mentioned that David is a giant in this field of psychoneuroendocrinology and women's health. And, you know, and I don't know if I can say that I have seen further by any stretch of the imagination, but so much of my work has been informed by the likes of giants like David, Kathy Wisner, who's also in the group, Patik Wadhwa, and Peter Schmidt, and Bruce McEwen, and what have you. So I guess I would like to say humbly that I hope that over the course of my career that I have made the giants in my life proud. So thank you so much for all that you all have done to really push the field of psychoneuroendocrinology and women's health forward, particularly in the areas of reproductive psychiatry. So in any case, as Audrey said, I'm going to focus here on our data looking at childhood adversity and how that increases risk for various issues, not only for the mom during pregnancy and postpartum, but also her developing fetus and then the baby. So I have a few disclosures, and I would arguably say that they don't really relate much to what I'm going to speak about today, but I'll let you judge for yourself. So again, I'm just going to provide a little bit of background just to help sort of center us on what's, you know, understanding why I'm going to be talking about preconception stress, its impact on pregnancy, fetal development, as well as mom's psychophysiology. And then we're going to go into the postnatal period. Because again, these hormonal milieus are, you know, couldn't be more opposite. So How many of you all remember this Time magazine article edition? Well, when this came out about a decade ago, and yes, when I looked at the date, I had to scroll up to see and magnify the date. This really was about a decade ago. Many of us in this room said, well, it's about damn time. We've been talking about 0 to 3 and, baby health. And again, I think that childhood mental health and infant mental health is really important. But I always tell people who are interested in infant mental health, you have to kind of go back at least 9 months. And look at what's been happening in utero. But I hope that by the end of today you'll recognize it is not just about the 9 months of gestation, but it really is about an intergenerational effect on basically what we are doing as a species and how we kind of face our environment moving along in this world. And so we know that this period of time in utero is really informed by mom and dad, but also baby's genetics, the placental development and how the baby, influences and basically controls the placental development. But we also know now that the environment that the mom and the father experience throughout life has an impact on what happens in utero, as well as what happens sort of in how they parent later in life. And I always tell young people, because when I went to medical school, we didn't talk about epigenetics. I had no idea what it was. And so I have to throw epigenetics on like one of my very first slides so that you think I'm really smart. The bottom line is that we do know that this kind of gene by environment interaction and changes that go on in the genetics and in gene expression and what have you is also incredibly important to this story. Now, no matter what your parents went through and how your pregnancy went, we are born into this world with a temperament. We're born into this world and we respond to environmental cues. And hopefully this is all of us, that we look at everything that happens to us with open arms and, we embrace the world and we think that it's such a great place and we interpret even the most negative of difficulties, like say, oh, this is a learning opportunity. How many people use that? You try to turn a challenge into, oh, I learned so much from that, So that's great. That's really important because how you deal with stressors later in life partially is about how you respond and your view of the world. Unfortunately, this is most of us. And if you think about this and how you're born into the world, you hope that you're going to embrace things and you hope other people embrace you. But if this is your temperament, even your mother's not really wanting to embrace you so much. So this reciprocity is also incredibly important because the last thing I want to do is say it's all about the moms or it's all about the dads. It's about us, okay? It's about you. It's about me and how we embrace the world. So we know that it's not just pregnancy or preconception, that stress has an impact across the reproductive life, across development. And I was just telling Kathy, she showed me a beautiful picture of her grandbaby. And I was like, it is an adjustment, even becoming a grandparent. We are constantly developing. God only knows, I hope we're constantly developing. And stress, and the stressors, not only type, but the timing, can have an impact. So, for example, how many people know the widower effect? That if you're an older gentleman and you lose your spouse, that you're like, 3 times more likely to pass away within 3 to 6 months of losing your spouse. If you're a female, so that might be a gender difference, a sex difference, what have you. But if you're a female, for example, you typically live older, so you're much more likely to, or live longer, you're much more likely to be taking care of a sick spouse. And basically, we know that that has an impact on, say, for example, glucocorticoid response to stress as well as immunity. So again, stress can have an impact not just in the developing fetal brain, but all across the lifespan. Now, for women, we have this issue called reproductive cyclicity and hormones, and our ovaries are kind of doing gymnastics. And so we know that in puberty, we have an increased risk of premenstrual dysphoria. 3 to 5% of women will have pretty significant symptoms and meet criteria for PMDD. Again, you heard from David, peripartum depression, incredibly common. Again, the most common complication of childbirth. I mean, just let that sit in. Everybody thinks it's like hemorrhage, infection, and those kinds of things. Postpartum depression, oh my gosh, is so, so common. And then into perimenopause, even if you've never been depressed before in your life, data from the Penn Ovarian Aging Cohort shows, and others, longitudinal studies show that women are about 2 to 3 times more likely to have a major depressive episode in the perimenopause. So our brains are having to manage these hormonal fluctuations. And I hope that if you took a point, away from David's talk, is that these hormones have profound impact on neuronal function and structure and communications and synchrony. And so we think about what's happening in the female brain, and I always call it the fantastically flexible female brain, because we really do have to do these mental gymnastics, neuronal gymnastics. I mean, we're doing triple Salchows, when we go through pregnancy. And then if you think about other medical conditions, it's not just about brain conditions. There's a whole host of medical conditions that have fluctuations with hormones, at least in their severity in some women. Now, men are a little bit different. Instead of doing triple Salchows, their hormones are doing handstands. Basically at puberty, you get an increase in androgens, and yes, there's some diurnal fluctuation, but men can actually father a child into their 90s. I think the oldest documented father was like 94 years old, and I'm like, just because you can do it doesn't mean you should do it. I mean, seriously, people. But, if in the group that is interested in sex differences, and again, my collaboration with Tracy Bale that I'll be talking about when we were back at Penn together, really did sort of sensitize me much more to the issues of sex differences. And how many psychiatrists are actually here, people in the mental health field? Okay, so great, so a few. So as you know that there are sex differences in many aspects of neuropsychiatric disorders, and that for males, the sex bias for ADHD, attention deficit disorder, Tourette's, autism, all of those things, you really see that sex bias occurring prior to puberty. But the sex bias in affective disorders, major depressive illness, PTSD, panic disorder, those don't really occur for females until after puberty. So again, people are looking at different parts of development and the hormonal exposures as part. It's not all about hormones, but in part, they're looking at these timing factors to say, okay, well, maybe the sex differences and the types of neuropsychiatric conditions you're going to see in one sex or one gender more than another has a lot to do with periods of development and hormonal exposures during those periods of development. So in any case, keep in mind the fantastically flexible female brain, okay? All right, so I'm not going to talk too much about neuroscience, but I do want to give one example of a gonadal steroid stress hormone interaction that I think it's really important. But I would also, and I challenge every audience, I always say, if you can raise your hand and give me an example or tell me a neurotransmitter system that is not in some way affected by either estradiol, progesterone, or allopregnanolone, I'll give you $100. And no one has yet been able to do that, okay? So in any case, I'm just going to focus on estrogen. So the estrogen and serotonin. Now, basically, tryptophan hydroxylase is the rate-limiting enzyme for the conversion of tryptophan that you get through your diet. You guys are going to eat a lot of turkey over Thanksgiving and all that dressing and gravy and stuff, and you're going to get a really massive load of tryptophan. Now, basically, tryptophan gets converted to serotonin by the action of the rate-limiting enzyme tryptophan hydroxylase. Estradiol actually increases expression of that particular enzyme. It also, once you release serotonin into the synaptic cleft, then you've got all that serotonin in the cleft, and it has to get either bind to receptors, pre- or postsynaptic receptors, and then it also has to be degraded in some way, shape, or form. So we all know that monoamine oxidase is the enzyme that degrades serotonin, and guess what? Estradiol decreases the activity of MAOA, okay? So basically, increased synthesis, decreased degradation. Now, you've got to have receptors for all that serotonin in the synaptic cleft to bind to. So PET imaging studies from my group and Edie Moses-Coco at Pittsburgh have shown that if you give estradiol, or in higher states of estradiol, you get more of those postsynaptic 5-HT2A receptors. So more synthesis, less degradation, more receptors to bind to. Pretty cool, huh? All right, so this would give you the idea that estradiol has pro or anti-serotonergic action. Which one is it? Pro, thank you, pro. I'm going to ask you guys questions, okay? I got to just make sure you're still out there and awake, okay? All right, so just speak up. So we all know that the 5-HT1A receptor, one of its jobs is kind of turning off the faucet of release of the presynaptic neurotransmitter, and estradiol seems to decrease the binding of that receptor in some brain regions. Now, why am I using this as an example? Because in studies where they've looked at early life and chronic stress using rhesus macaques, basically subordinate monkeys are chronically stressed. Dominant monkeys are not so stressed. And basically, if I'm going to be reincarnated, I'm asking all the reincarnation gods not to send me back as a subordinate monkey. It is not a good life. You're depressed, you have a depressive phenotype, you have increased risk of various medical problems. It's just not a great life. And what the studies have shown from a number of different groups, Carol Shively and Vasiliki Makopoulos down at Emory, is that if you're a subordinate monkey and have had a lot of chronic stress, that you don't have as positive or pro-serotonergic effect of estradiol. So you have, estrogen affects the brain, but you don't quite, it doesn't pack the same punch for you as it does for that dominant monkey, okay? So again, it's a suggestion that early life stress, chronic stress, particularly during development, can have adverse effects on how hormones affect the brain later in life. And we also know another giant, Marty Teicher, has done amazing work looking at the impact of different periods of time of stress in humans and how abuse and neglect in specific impact particular brain regions. And he's done a number of neuroimaging studies that show that if your adversity occurs between the age of 3 and 5, you're going to have more effects later in life in the hippocampal region, 9 to 10, midline structures, and then obviously in 14 to 16-year-olds, we're really talking about prefrontal cortex. What do these brain regions and timings tell you? It tells you that when the area of the brain is really, really developing, that's kind of when, prime time for development, that is not a good time to be maltreated. Those cells, those systems, those neural networks can be adversely affected because of that process. So again, timing is really important when we start to think about these things. So I just want to move into talking about sort of preconception stress and pregnancy. So during pregnancy, I hope you appreciate the brain is taking a bath. It is, again, soaked in these gonadal steroids, estradiol, progesterone, allopregnanolone. I mean, quite frankly, as you heard from David, allopregnanolone is a GABA-A receptor agonist. And the amount of allopregnanolone that women's brains are exposed to during pregnancy, we should all be asleep our entire pregnancy. Quite frankly, I mean, it's like you've got a benzodiazepine, a barbiturate just like floating around up there. So again, what is it? The fantastically flexible female brain, right? All right. So this female brain is having to adjust because, quite frankly, a lot of us do just fine during pregnancy. We're not comatose. We're not zombies. We're functioning. We're going to work. We're taking care of stuff. However, there are people that are more or less sensitive, and I've had patients who have come to me and said that, surgeons in particular, saying that they felt like their fine motor skills, particularly if they're having to work with small organs and doing microsurgery, that they felt like as they got further into their pregnancy that their motor coordination was not as good. And I'm like, well, no wonder. I'm surprised that that doesn't happen to everybody, but it doesn't. Now, the other thing is not only are we having this unique hormonal milieu due to this gonadal steroid bath, you've got this HPA axis thing going on, you know? I mean, and basically during pregnancy, unlike any other time in an individual's life, you've got this feed-forward effect of glucocorticoids on CRH. So, and correct me if I'm wrong, I think this is the only time in humans when it's normal to have high levels of glucocorticoids as well as CRH, or because Tracy is a basic science researcher, CRF. The bottom line is that this process is really unusual to have high levels of glucocorticoids in CRH or CRF. Okay, and this is really important because even stress during pregnancy can alter these relationships, alter the amount of CRH that would be, quote, quote, normal for pregnancy, alter levels of cortisol. And we know that particularly during pregnancy, you know, timing of whether it's first trimester, second trimester, or what have you, the timing of the stressor, the type is really possibly also important. So, like, even though Tracy will tell you that, you know, the cell can't distinguish between, you know, types of stressors, whether it's depression, anxiety, whether it's food insecurity, whether it's hypoxia due to sort of placental insufficiency, or maternal chronic health conditions. Again, in a number of these kinds of stressors during pregnancy can have different effects. And I'm going to show you some data from my group and others where I think that the type is important when it comes specifically to some of our outcomes. And then again, we're going to talk about the importance of offspring sex because that is a growing area, and you'll hear that also from Catherine Monk. So I told Tim Oberlander that I would show a piece of his work. I told you the picture was big. This is what happens when you have a new program for your slides, and it gives you ideas, you know, and it goes, wow, this is a great idea for designs. And I'm like, yeah, I do like it. So Dr. Oberlander, professor at the University of British Columbia in Vancouver, has done some very interesting work, again, trying to get to this mechanism of understanding how maternal psychosocial distress can have this adverse effect on child neurodevelopment. And we know that that happens, but we're not really quite sure how. And there's a number of people that are starting to really look at this. And in this particular study, doing, you know, following about over 100 women and their children, and then following the children and being able to measure things like their basal cortisol levels, their stress responsive. So really looking at the child's HPA axis and saying, does the child's response to stress or basal levels of these glucocorticoids actually, is that mediating mom's effect during pregnancy on the child's neurodevelopment? And in this situation, the outcome was executive functioning, which I don't know about you, but I really value my executive functioning. And so it's what helps us get through the day. And bottom line, and this is something that I'm going to repeat over and over again, the effect was there primarily for boys. That boys' HPA axis response to stress and basal levels of stress, or stress hormone, during this particular age is what mediated, or, you know, again, you can do these statistically, these mediation analyses, mom's depression and anxiety on the child's executive functioning. But it was there for boys. Okay, that was the most important takeaway that for me is that this was a sex difference. And the truth is that, you know, Pratik Wadhwa's group and Claudia Boos, who's been a long-term collaborator, I don't have a slide on this, but has also shown that when they looked at girls at 6 years of age, and again, they were looking at a different outcome. They were looking at a neuroimaging outcome, an amygdala and hippocampal volume, and they were looking at moms in pregnancy, not at her affective state, but her cortisol level. So again, when you change what you're looking at, you can get a different effect. But the effect in that situation on the outcome of interest, which was amygdala volume, was seen for girls. Okay? So again, we have to be thinking about sex of the offspring, particularly when we're thinking about different markers of effect of either maternal adversity, maternal stress, maternal psychosocial distress, whether it's depression and anxiety, and its impact on the outcome of the infant or the child. So again, thinking about this with respect to sex is incredibly important because you'll miss the finding otherwise. Now, Megan Smith, who works with Kim Yonkers at Yale, they've done a nice longitudinal study, and this is getting to the mom's adverse childhood experiences. So not her stress during pregnancy. They controlled for her affective state during pregnancy, as well as other factors in pregnancy that are associated with having undergone a lot of early life stress. And basically, they've looked at gestational age at delivery and fetal birth weight. And basically, they showed that even if you control for a bunch of other stuff, because yes, most of the maternal effect of ACE, or adverse childhood experiences on, particularly in this case, birth weight, was due to behavior, so like more likely to smoke during pregnancy or drink during pregnancy. But even when they control for those maternal factors, they saw that in moms who had experienced adverse childhood experiences, or ACEs, which I'll talk about more, that there was a 13 or 14-gram reduction for each ACE. So again, an independent effect of this childhood adversity. So one of the things that we've been trying to figure out is sort of how that happens. And Tracy and I, when we were both at Penn together, and again, I always say that one of the reasons I left Penn is that Tracy Bale was no longer there. It is absolutely, as a clinical researcher, it has absolutely been my bucket list, pipe dream, what have you, to work with a basic scientist like Tracy. And it was just so much fun. Really, I miss you. So in any case, these are data that we obtained during our P50, and those of you who know the P50 mechanism, usually it's about a collection of 3 R01 type studies that are really meant to promote interdisciplinary research between the basic and clinical so that you get that translational continuum. And so I thank ORWH, the Office of Research on Women's Health, for really putting out this particular mechanism. And we focused on childhood adversity in the humans, early life stress for the rodents, particularly in the peripubertal, prepubertal window, and how that impacted pregnancy outcomes. And then I was also the PI for the study focusing on menopause. I am not going to go to the menopause at this point because that's not the nature of this particular group. But in any case, we've also found some very interesting enduring effects of ACEs on our menopause population as well. So those of you, how many people have heard of the ACE study, adverse childhood experiences? I don't have to go through all of it. But basically, the idea is that you give people a 10-item questionnaire. It's very easily to be, we could have done the childhood trauma questionnaire. We could have done the traumatic life events questionnaire. But the reason I went with the ACE interview is because there was so much data showing an impact on a number of health outcomes, whether it's autoimmune disease, migraines, substance use conditions, obesity, cardiovascular disease, likelihood of losing your first baby in pregnancy. So there's just so many ways in which the ACE study has been used, and it's been replicated across a number of states. And we know that it increases for each additional ACE, and the sweet spot for a lot of disorders is 4 or more. But we're going to show you that in our hands that 2 or more ACEs is sufficient to demonstrate risk. And so we use that in the human model. In the animal model, Tracy's group took mice and did a chronic variable stress model, an idea of trying to recapitulate the sort of the kind of chaos or kind of stress in the environment that you might have if you're a high ACE individual. Obviously, you can't really recapitulate the emotional aspects of abuse and neglect, but in any case, we felt like this, and working with her, I'm convinced that this is a really good model. So the mice, over a course of 2 weeks around the peripubertal window, get exposed to a number of different stressors, and then they're allowed to sort of just grow up normally. And then you can test them in adulthood, either during pregnancy or prior to pregnancy, or you can test them postpartum. And so I'm going to show you some data that really shows that this mouse model has actually also been very helpful to us in our looking at our human subject studies. So we took about 1,200 women from an inner-city OBGYN clinic, and we basically just asked them, because we were trying to get them into the longitudinal study, and what we found is that, obviously, as you would expect, that many of our ladies in the high ACE group had a larger BMI. They were more likely to be African American, unmarried or divorced, have lower educational status and income, and their baseline perceived stress in this large sample was also higher. So we had to control for all those in all of our analyses. And so we basically looked at gestational age at delivery This looks like a very non-significant effect of ACE, but we did see, because of the sample size, that there was a significant in the unadjusted model. Again, if you don't adjust for all these issues, it does look like the high ACE women deliver earlier. If you adjust for race, perceived stress, and age, you wind up seeing that there is no effect, at least of early life stress, on gestational age at delivery. And then, because I know Catherine's going to talk a little bit about the importance of fetal sex, I just said, okay, let me go back and look and see if our high ACE ladies were more likely to have baby girls or baby boys. And basically, those of you who know about evolution know that under times of extreme environmental stress, a female is more likely to have a female child because, I mean, well, it's for obvious reasons, I think. And here we did see that under high stress, that they were more likely to have a female child, at least with respect to percentages. I do have that correct, ladies, right? Female child, okay, good, all right. I was just looking at, and then in the low ACE group, we had more boys, okay? That was not significant, again, when you controlled for all these factors, but even if this is true, when you think about millions of births each year, it might actually become a significant finding, but I just wanted to look at that in our group. Now, one of the reasons that we were trying to think about, well, how does mom's early life stress? Does she respond to stressors differently in pregnancy? And does that have an impact on baby's HPA axis development? And so we decided to do something called a 3D ultrasound where we can look at fetal adrenal volume because it's the end organ. We can't actually use imaging like this to look at things like the hypothalamus or pituitary, but we can measure adrenals. And basically we took about 130 women from that 1,200 and who did this longitudinal study. And we basically used, again, the ultrasound to measure the adrenal volume. And in this smaller sample, the biggest differences are the moms in the high ACE group had a larger BMI, were more likely to be African American, and again, those factors that you see there that are significantly different in the direction you would expect. But they're perceived stress scores in pregnancy, and that was something I was really pleased to see, is that even if you were a high ACE mom, you weren't more stressed, or at least you didn't report more. Now, I can't say that they weren't objectively more stressed. I can only say their perception of their experience was not one that was higher. And in this sample, the average number of ACEs was about 3.6. So one thing that I want you to take away from this slide is two things. If we just did this study where we got a bunch of fetal adrenal volumes, and we did not look at the outcome by maternal ACE, we wouldn't have had a finding. Likewise, if we had looked at the outcome and not thought about fetal sex, there would be no finding. Okay? So those are two things that are really important, and I want you to take away from this talk, is that I really believe that most of our research in humans really needs to be thinking about early life adversity, because I've seen it over and over again alter my outcomes of interest, and we have to think about sex or gender, depending upon what you're studying, okay? Those two concepts. Because here what you see is that in the females, you've got low ACE and high ACE, and the males, you've got low ACE and high ACE. There is a maternal ACE by infant sex interaction here, such that basically you don't see that much of an effect in the girls, but you do in the boys between the low and the high ACE. That's a highly significant difference. And if you were to blend all of this together, you wouldn't see any differences at all. So the important thing is that thinking about maternal ACE and infant sex is really important to see this three-way interaction, or this interaction. So we wanted to understand, okay, so that's the fetal adrenal volume. What does it mean? How do we think about it? Is that going to have a long-term impact on baby HPA axis response? And is there something going on in pregnancy with mother's psychophysiology that leads her to have this effect on the baby's HPA axis? And so what we did is we did an affective modulation of the acoustic startle response. You put people, you hook them up, put probes around their eyes. The startle response is really conserved across species. You give a loud noise burst. It's kind of noxious, and people blink. And you measure the strength of the eye blink. And basically we know, and David talked about states, the affective state, the appetitive state, or the aversive state of the individual can either dampen the startle response or accentuate the startle response. I mean, if you're really stressed out and somebody comes into the room and you're not expecting it, you're going to jump. But if you're like all happy watching a funny movie, you know, somebody could be, King Kong could be at the door, and you probably go, oh, hello. It's nice to see you, King. So the bottom line is that we wanted to see if the psychophysiology, because it is also tied to the HPA axis as well as modulated by allopregnanolone during pregnancy. And basically we're seeing that between the high and low ACE women, there's absolutely no difference. This is a resoundingly negative. They all respond to pleasant, unpleasant. Oops, I did the same thing, David. Unpleasant or neutral or pleasant images. They responded the same. And they had a very similar cortisol response. So, bottom line, they didn't find this particularly stressful. Everybody was more stressed by their daily hassles of life. I mean, but they came in more stressed than they found this particular procedure. So, it wasn't mom's, response to her psychophysiology. We yet do not know why we saw this sex difference in fetal adrenal volume. Now, focusing on the postpartum, we did the same thing at 6 weeks postpartum. Now, again, they've had this amazing drop in allopregnanolone, amazing drop in changes in their HPA axis, and now you can see that it doesn't matter whether I'm showing them pleasant, unpleasant, or no images at all. The high ACE ladies are startling more. Okay? So it seems that there's something about going into the postpartum period that is changing how these ladies respond to this particular stressor. So we decided to take this a little further. What's happening with moms and babies at 6 months postpartum, and how are they responding to stress? And then how does ACE have an impact on that, or does it have an impact on that? And we have a lot of research coordinators who did a great job, because we were initially going to just focus on 6-month-old babies. But we found that the babies, when we took the babies away from the mom for them to have a stressor, our research coordinator said, we can tell our high ACE moms from our low ACE moms. And I was having lunch yesterday with one of our research coordinators, and she said, oh, those high ACE babies and low ACE babies also responded to the stressor differently, at least in how they presented to them. So we started thinking, wow, we really should be studying the moms, because maybe infant separation is an ecologically relevant stressor for these mothers. So basically what we did is a study where we took the infants and we measured salivary cortisol for both moms and babies, and then the babies were taken away from mom and they underwent a restraint stress for 3 minutes. Their little hands were held down and the research coordinators couldn't do anything. They had to keep a very straight face. And they said, oh, these babies were so cute. She's like, they would do everything they could to get you to smile at them. They would be like, they would look at you and make faces, but they would always try and get you to smile. And then they did a bullhorn, 3 blasts of a bullhorn. So babies would have to listen through all of that. If they cried for more than 20 seconds, we took them back to mom and stopped the procedure, but we continued collecting salivary cortisol. A lot of babies tried to get you to smile, thought it was funny. Some babies cried, and then some babies just got mad. Now, the high ACE or the low ACE babies, what do you think they were more likely to do? They were more likely to cry. The low ACE babies. She's like, those low ACE babies were definitely wimpier. I was like, okay, well, let's not say that. I mean, they're only 6 months of age. I don't think we want to start calling the low ACE babies wimpy. But no, she was saying, the high ACE babies just kind of thought that this was like not a big deal. And guess what? The high ACE moms also didn't react very much to us taking the babies from them. So this is how we set up the study. Tracy's research coordinator, her postdoc, Katie Morrison, and I'm going to just show you the data that was published in Biological Psychiatry, but also we have follow-up data on about 50 more moms that I'll also show you. So in any case, Katie said, well, I could actually create an animal model that is similar to this. So basically, they use the chronic variable stress, stress the moms, let them grow up, have babies, and then they did a separation test. This is the data from the humans, and basically you can see that our low ACE moms had a higher cortisol response compared to our high ACE moms. So they didn't find it as stressful, the high ACE moms. And we've now replicated this with 75, so it's always great when your data replicates when you triple the sample. But in any case, again, high ACE moms, higher cortisol response, more dampened, and the high ACE moms. So in the animal study, they separated the moms from the pups. They could smell the pups, they could hear the pups, they could see the pups, but they couldn't get to them. And they measured corticosterone to see how they responded. And basically what you can see is that the control moms, the moms that did not have early life stress, they kept running around trying to get to their pups. They wanted to get to those pups. And that the peripubertally stressed rodents did not. They just basically gave up. Said, those pups can sit over there on the other side. And you also see what we saw in the humans. You see in the stressed moms, peripubertally stressed moms, a dampened cortisol response or corticosterone response. So this was what I live for. I mean, as a clinical researcher, I actually live for the opportunity to actually be able to have an animal model that reflects what's going on in the human or vice versa, because they were able to take the periventricular nucleus of the hypothalamus and other brain regions and look at genetics and changes in gene expression. Can't really do that in humans. I don't think people are going to allow that. And what we find is that, or what Tracy's lab found, was that there was very much a different upregulation of a number of different genes in the PVN of the stressed mice that weren't there in the non-stressed mice. So what about the infants? Well, again, if you didn't look at sex and you just looked at ACE, so this is the low ACE babies of low ACE moms, and this is the cortisol level of the high ACE. Now, again, it looks dampened, but, you know, there's a lot of variability in human subjects, and so that's not significant. But when you tease it apart and you look at sex, you now see that basically high ACE girls are up here, and then the low ACE boys are way down here. And what really is very interesting is that the low ACE boys look a lot more, the high ACE boys look a lot more like the high ACE moms. Okay? So it appears again that mom's early life adversity, at least when it comes to fetal adrenal volume, and then 6 months of age postpartum, that the babies have a different response if they're of a high ACE mom versus a low ACE mom. And the effect really does seem to be driven by the male offspring. So, in summary, maternal early life stress impacts the fetal adrenal volume in a sex-specific manner. You have to look at it by ACE and you have to look at it by sex, or you don't see the effect. Maternal cortisol response to stress, if she has high ACE, she's dampened. She's not finding it as stressful, and behaviorally, she doesn't look as stressed. And the same thing is occurring with her male offspring. Psychophysiology can't seem to explain what's going on and how we're getting this fetal adrenal differences because the moms look completely the same. I think that's probably because they're getting so much allopregnanolone you can't see an effect of ACE. But in the postpartum period, when you have withdrawal of allo, withdrawal of CRH and cortisol, you do see an impact of maternal ACE on her psychophysiology. So clinical ramifications. I think ACE history is important. Those of you who do clinical research, I would say I don't care if you think it's not going to have an impact because I can show you our menopause brain imaging data and show you that it really has an impact. And these women are 50s and 60s. Okay, so this is an enduring effect. And we don't really understand sort of why we're seeing these differences in pregnancy, to be quite frank, and something we're going to have to continue to work on. And I can't tell you that a dampened stress response, and I think this harkens to what David was trying to say, whether you're an orchid or a dandelion, it's hard to predict, because a lot of it is not only how you respond to stress, but now the environment that you find yourself in. But a male child who has dampened stress response becomes a male adult, and if a male adult has a dampened stress response, that's also been associated with psychopathy and a number of other things that are concerning. You need to have a normal stress response to be able to pay attention to relevant stimuli. So again, I can't tell you if it's good or bad. I can just tell you what we found, and what we really need to do is take these data and follow children under different environmental circumstances and see how they do in life. And the final thing, please do not ignore sex differences, gender of your individuals that you're studying, working with, because it has clinical ramifications as well. And please keep in mind the impact of diversity. Okay, we have a large group of people helping, and thank you to all of our funders. And I will take a question if we have any time. Yep. Gentlemen, yes, go ahead. Just shout it out, and then I will shout it out. Wow, great. No, I appreciate you sharing that. Thank you. Did everybody hear that? Okay, so he was pointing out that a gentleman conducted some research in people with chronic depression as adults. And obviously we know that depression, the disease burden of depression for females worldwide is about twice that of males. And so not that men don't get depressed and not that men don't have chronic depression as well as females, but in his study he was showing very similar effects, that the males had blunted cortisol response and the females had accentuated cortisol response, which is very similar to the response that I showed you in the 6-month-old infants. And obviously, you probably don't have those individuals' ACE history, but a lot of people would have if they're experiencing chronic depression, because we know that childhood adversity, whether it's abuse, neglect, what have you, it also is a major risk factor for chronic depression or depression that is less responsive to the treatments that we have. And so I would imagine if you went back and got the ACE score on a number of those patients, that you would find that they fell into that high ACE category. Yes, Tracy.
Fabulous talk.
Thank you.
Provocative and very, I think, engaging in terms of maternal preconception.
Yes.
I wondered if you wanted to, especially with this audience, comment on what we oftentimes forget about. We talk a lot about sex and gender of offspring, but what about sex and gender of?
Yes.
And so preconception, dad being a factor as well.
No, that's an important point, and I hope that you will talk about it a little bit. But, I mean, there is relatively little data out there in humans looking at the impact of father's early life adversity. I mean, I know that Rachel Yehuda has done some work looking at men in different ages that they were when they were in concentration camps in Nazi Germany, and so, or Austria, what have you. And the bottom line is that there does appear to be also an important factor for paternal stressors at certain ages having an impact on offspring, and whether that offspring is a male offspring or a female offspring. But we really are hoping to do more work and promote people doing more work, not just focusing on moms. And if you are going to focus on moms and her early life stress, it is important to also get dad's history. And that way you're sort of looking at both sides, because not only does a sort of a harsh upbringing increase the risk as a parent that you're going to parent in a harsh way, which can have adverse effects. So those environmental issues, but there is a lot of data coming out of basic science laboratories, and Tracy's in particular, really focusing on the sort of biological changes that are there for both males and females and what they contribute to their offspring, not just through the environment of parenting. Yes, ma'am, back in the back. You. Yes.
Quick question. I'm wondering if there is any correlation between the high ACE and low ACE mothers and suicidality.
Well, in our study, no. Because we were looking at ladies we actually excluded ladies who had any kind of major psychiatric treatment or illness in our longitudinal sample. And then in our 1,200, we did not sort of look at that, but I don't know that anyone in that group actually did have suicide. But yes, adversity certainly increases not only the risk of having a chronic psychiatric condition, bipolar disorder, ACEs are associated with increased risk for schizophrenia, alcohol and substance abuse, and again, chronic depression, and all of those are risk factors certainly for suicide or suicide attempt, suicidality, and either ideation or attempt or completion. I don't know that anybody has actually focused on ACEs or traumatic life events specifically in postpartum suicidality, but it's a really good question. Good study. Yes, anything else?
So Neil, right here.
Oh, okay. Oh, yeah. Hi.
Hi. Thank you for
sure.
Extremely elegant presentation.
Sure.
I was curious about whether with the high ACE scores, while they were being part of the study, were any of them on medications?
No, we definitely were looking. And so in some ways it's a rarefied population. At least at that time point, they were not suffering from depression, anxiety, and they were not on psychotropic medications. And so, because again, we were trying to help them be as close to the low ACE group in pregnancy as possible, but you still saw that they had higher BMI, they'd be African American, lower education. And again, I was doing this in Philadelphia, and that is more, the population in Philadelphia is more diverse. Yeah.
Mm-hmm. And so my second question is, I was wondering, and I know we'll get to interventions, but as a psychiatrist, obviously the data are very alarming. Can you comment on what type of therapies have been proven effective in improving the mom's conditions and thereby hopefully improving child outcomes?
Well, that's a really good question, and I wish I had a better answer, a more optimistic answer. Quite frankly, there's there are very few studies that really focus on our treatment and stratify by either things like HPA function or even immune, sometimes people have looked at various medications and treatments for depression that have an impact on cytokines, or they didn't even measure baseline, they sort of post hoc measured baseline cytokines and showed that they were more effective if the cytokines were higher. So we've got a lot of ways in which we do randomized clinical trials, large-scale studies, because you're not wanting to tease apart some of these things in some of those pharma studies. And I would love to see pharma studies and also people doing psychotherapy studies to really focus very specifically, is this treatment better if the mom has had early life stress, a lot of adversity, or not? And if we could push that envelope further, and hopefully somebody will stand on my shoulders someday and hopefully push that research further. But it is really lacking at the moment. All right, Danny, and I think that'll be it because I know we got to move on.
So.
Oh, no, yeah. No, Danny's over there. Wow. Okay. Sorry.
Danny number 2. Thank you. This is great.
Sure.
I'm just your paradigm.
Mm-hmm.
Or accept. Obviously, approach is quite proximally. So I'm wondering.
Separation paradigm for what? I'm sorry?
Attachment.
Attachment, yes.
And so what I'm hearing from the response, I'm hoping maybe to have your reflections on that, mm-hmm. is in what way what you're observing as a response is really mediated in some ways by the attachment, mm-hmm. which we also know is transgenerational. Responses of the infant, the one who's actually still crying, he's still able to fight,
yes.
saying, I don't think this is okay,
yes.
versus the baby who's already in some ways reflecting, attachment modifications in a parent with, at least if they have these sort of traumatic antecedents, are also going to have some likely effect on the dyadic responses, and then to what extent this child's already expecting or used to these types of sort of non-contingent responses of caregivers. So I'm just wondering, your thoughts about the role of attachment as one maybe of the mediator mechanism.
Well, I think that's a great point taken following Catherine's point, because there are people who work on infant mental health, and they often will work on attachment and issues of attachment. So yeah, I completely think that what you're talking about has merit. I can't say that we, kind of measured attachment, which I wish we had in a little bit more of a sophisticated way. But I have no doubt that a lot of it has to do with sort of an adaptation of these babies' response to the mom, and how can we actually create therapies that really work on enhancing that. And that's some of the work that people are doing at my institution in the Harris Infant Mental Health Program, is trying to, again, manage those kind of attachment issues. I don't think that they've been doing it in a specific way. They've just been trying to do treatments, but I would arguably say it's probably a lot due to things like attachment. So, and again, adaptation. We adapt. The infant adapts. And whether that adaptation is a positive adaptation or a maladaptive adaptation is yet to be seen, depending upon the environment that they're in. All right. Well, thank you so much. It's been wonderful.